Good evening. I want to welcome everyone for this last session, and I want to thank everyone for sticking around for this session. I'm one of the moderators of the session related to the original abstracts and studies. It's my pleasure to introduce Dr. Aurélie Scheer. Dr. Scheer has graduated from the Holy Spirit University in Castleek in 2020. She's specializing in radiology at Centre Hospitalier Universitaire Notre-Dame de Secours in Jbeil. The work she's about to present to us was the result of a year-long thesis under the patronage of Dr. Elisar Dager. She did a radiology clerkship at Cochin Hospital in Paris and earned a certificate in psychological first aid from Johns Hopkins University. And she's the head of community service in Rotaract Club of Kisserwen. Dr. Scheer is going to present obstructive sleep apnea, evaluation of knowledge, associated factors, and identification of high-risk individuals among a representative sample of Lebanese adults. Once she's done, I think we're going to address the questions related to her presentations at that time, but she will stick around, obviously. And if anyone has additional questions, we're going to address them later on towards the end of the session. Dr. Scheer, the floor is yours.
Mesdames, Messieurs, bonsoir. Mes plus vifs remerciements au comité de la Société de pneumologie de m'avoir accueilli. Je suis honorée d'être parmi vous ce soir. Je vous présenterai l'étude faite avec Dr Elisar Daher sur l'apnée obstructive du sommeil, l'évaluation des connaissances et identification des individus à haut risque au sein de la population libanaise. Qui parmi nous ne connaît pas au moins une seule personne qui ronfle la nuit ou qui ne dort pas, qui dort durant la journée? Selon la CDC, le trouble de sommeil est une épidémie de la santé publique. Durant les dernières 2 décennies, la prévalence de l'apnée obstructive du sommeil a augmenté. Cette prévalence varie de 9 à 38%, dépendamment des communautés. Au Liban, il n'y a qu'une seule étude qui a été faite à Beyrouth qui montre que 31% des individus participants avaient une prévalence assez élevée de risque de développer cette pathologie et que seulement 5% avaient été diagnostiqués par un médecin. Ceci rend cette pathologie plutôt sous-diagnostiquée. Au Singapour, à Lorraine en France et à Riyad, des études ont été menées sur la connaissance de la population et toutes aboutissent à un manque de connaissances. Les patients devraient être plus conscients des symptômes qui devraient les pousser à consulter. Plusieurs études ont montré la positivité d'une relation entre les connaissances et l'application de mesures préventives et la compliance. Selon la WHO, l'apnée obstructive du sommeil est un trouble de respiration aboutissant à plusieurs comorbidités. C'est un collapsus partiel ou complet des airways qui mène à des apnées et des hypopnées durant le sommeil, montant à une saturation d'oxyhémoglobine qui est diminuée, une hypoxémie malgré les contractions du diaphragme menant à plusieurs réveils durant la nuit. Voici les symptômes qui sont déjà connus. Les étiologies sont multiples. Nous en relevons bien sûr le sexe et l'âge, surtout l'obésité. Avec chaque augmentation de 10% du poids, nous aurons une augmentation de l'index d'apnée-hypopnée de 32% et 6 fois plus de risque de développer l'apnée obstructive. Voici la polysomnographie pour le diagnostic et sûrement la classification de l'apnée-hypopnée index qui sera supérieure à 15 épisodes par heure, confirmer le diagnostic, ou à 5 avec l'un de ces symptômes que nous voyons ici. En ce qui concerne le diagnostic tardif, en 2015, l'Académie américaine de Sleep Medicine déclare une perte de 150 milliards de dollars aux États-Unis due aux conséquences de l'apnée. Ceci a été divisé entre la perte de productivité, les comorbidités, les accidents de voiture et les accidents de place. De plus, nous signalons les troubles neuropsychiatriques, les troubles cardiovasculaires, pulmonaires, la polycythémie, le diabète qui, en fait, selon Schuschmidt, 12% des patients ayant l'apnée obstructive développeront un diabète, et de plus, 30% des diabétiques ont une incidence plus élevée d'avoir l'apnée. Le syndrome métabolique, évidemment, et la stéatose hépatique. D'où la nécessité d'une étude au Liban. Aucune étude préalable n'a été faite au Liban sur l'apnée obstructive, ni concernant les connaissances, ni la prévalence, ce qui la rend toujours inconnue. Les études mondiales donnent des réponses assez diverges. Notre étude a été menée transversalement de juin à août 2019. 472 personnes ont été questionnées, prélevées de plusieurs CASA différemment au Liban. Voici le questionnaire que nous avons suivi. Les caractéristiques sociodémographiques, les maladies personnelles et ainsi que les habitudes, le café, le tabac, l'alcool, les connaissances qui ont été basées sur le questionnaire de Lorraine qui a été traduit en arabe, et les screening scales qui sont l'EPERS et le Stop Bank. Donc, nous avons inclus les adultes. Comme réponse, les résultats, nous avions eu 11% de personnes ayant été déjà diagnostiquées par un médecin ayant cette pathologie. Par contre, sur l'EPERS, nous avons eu 14,4%, 16,3% et 13,9% ayant des minimes, modérés et sévères somnolence diurne excessive. De plus, selon Stop Bank Questionnaire, nous avons eu 31,6% et 7,6% ayant des risques intermédiaires et élevés de développer cette pathologie. Donc, le diabète, l'infarctus du myocarde, l'arythmie et l'hypertension étaient tous associés à une somnolence plus élevée. Par contre, le diabète et l'infarctus du myocarde étaient directement associés à des risques élevés d'apnée obstructive directement. De plus, on note que 49,2% des participants avaient une connaissance très très basse concernant cette pathologie. Et évidemment, ceux qui avaient déjà entendu parler de cette pathologie avaient un score plus élevé. Les symptômes les plus connus étaient le ronflement, les stops durant la respiration, la fatigue durant la journée, les suffocations. En ce qui concerne les conséquences, elles étaient beaucoup moins connues. Nous relevons les accidents de route, les AVC, les arythmies. Donc, comme nous l'avons déjà dit, ce sont les numéros qu'on a eus. Et ce qui correspond évidemment avec Senaratna et al., que bien sûr la prévalence varie d'une population à une autre. De plus, concernant EPERS, nous avions eu en premier une prévalence plus élevée avec le diabète, ce qui pourrait être expliqué avec un dysfonctionnement autonome et une perte des voies aériennes et de leur innervation en fait. Et plus on a une hypoxie, plus le glucose, le métabolisme du glucose va être altéré et nous aurions une augmentation de la résistance à l'insuline. L'hypertension, qui est en accord aussi avec le journal of American Society of Hypertension, qui déclare que plus on a une hypertension, plus on a un sommeil qui est moins efficace et du coup, le système sympathique va accélérer et la dilatation pulmonaire va mener à une demande plus augmentée d'oxygène qui va aussi mener à plus de réveil. En ce qui concerne l'infarctus du myocarde, quand on a une augmentation de EPERS, ce qui est la somnolence diurne, nous avons directement un mauvais pronostic en post-MI. En ce qui concerne l'atrial fibrillation, nous avons par contre ces controverses. Donc, plus on a une fibrillation auriculaire, plus on aura des réveils fréquents et plus on aura un sympathique système qui va être activé et on aura une cardio-accélération. En ce qui concerne Stop Bank, nous avions aussi une augmentation avec le diabète. Ceci pourrait être en corrélation avec l'obésité, de plus avec une défecture microvasculaire qui pourrait altérer l'échange d'oxygène au niveau pulmonaire, qui est en accord avec Hamilton, et de plus avec les infarctus du myocarde. Donc, après une revue de littérature, nous avons trouvé une association entre OSA et les troubles cardiovasculaires. Donc, plus de 65% des patients qui souffreront d'une pathologie cardiovasculaire seront diagnostiqués d'apnée obstructive. Comme nous l'avons dit, seulement 25% des participants avaient une bonne connaissance de l'apnée du sommeil. Les gens qui avaient déjà entendu parler avaient de meilleures connaissances. Ce qui entre en accord avec l'étude menée à Lorraine ainsi qu'au Singapour, que les personnes ont toujours une minime connaissance sur les complications de l'apnée et même d'elles-mêmes, ce qui incite le besoin de beaucoup plus d'éducation dans ce domaine. Voici les limitations de l'étude. En conclusion, l'apnée obstructive a beaucoup de comorbidités. Il y a un manque de connaissances autour de la société libanaise. Et lorsqu'on compare que seulement 11% des individus ont été diagnostiqués de cette pathologie et combien sont à risque, on doit vraiment se poser une question sur le sous-diagnostic. Chaque individu devrait être assez éveillé sur toute symptomatologie qui devrait le pousser à consulter. Et des campagnes devraient être plus présentes et des dépistages ainsi. Et voilà pour les recherches suivantes. Bien sûr, nous devrons étudier les connaissances de tout physicien dans ce domaine. Merci bien de m'avoir entendu.
Thank you, Dr. Sher, for this very nice presentation. I think we're gonna keep the questions till the end of all the abstracts, and then we will discuss them. Thank you so much.
Thank you.
To the next presentation, and that's by Dr. Reem Hajej. Dr. Hajej has trained initially in Lebanon. She got a Master of Science in Functional Genomics at USG, and then she got another Master's in Genetics Development and Immunity in France. She went on to get her PhD in Germany, and she completed that in 2015. It was in molecular and cellular biology. It was at the University Children's Hospital in Münster in Germany. And then she received a grant from the German Research Foundation, and she's currently a project leader in the Department of Pediatrics at the University of Münster. And she's working on the genetic and the molecular characterization of defects in patients with primary ciliary dyskinesia. And today she's going to talk to us about PCD in a Lebanese population. Go ahead, Dr. Hajej, the floor is yours.
Hello, everyone. So I will be talking today about a first cooperation that we had between Germany and the Department of Pediatrics at University Hospital Münster and the Department of Pulmonology and Tobacology at Hotel Dieu de France Hospital and Saint Joseph University. So we were in contact with Dr. Georges Khayat, and we could do the first genetic screening in a Lebanese primary ciliary dyskinesia population, which actually have revealed uncommon disease variants. So just like as a quick start, so to talk about these hair-like tiny organelles, which are called cilia, which we can find on almost every cell type of the human body. So these cilia can either move, be motile, or be non-moving, so non-motile, and they can have also different structures to have a 9+0 structure where they lack the central microtubule, or have a 9+2 structure having like a central pair. So usually we concentrate on the motile cilia, the one which are moving, and the one with a 9+2 structure, which we can find in the brain, like at the ependymal cilia, the respiratory cilia, the cilia of the oviduct, the sperm flagella, and the epididymal cilia. So as I said, these are 9+2 structures, and they are motile. So in order for them to move, they need kind of like arms, and they have like outer dynein arms and inner dynein arms to like allow their motion. So as I said, we can find them so much, for example, in the brain. And if the cilia are not functioning properly in the brain, this will lead to hydrocephalus. This can lead also to female infertility and male infertility, since the cilia are present in these organs. It can lead to upper respiratory tract infections like rhinitis, sinusitis, nasal polyps, and also to lower respiratory tract infections like chronic productive cough and bronchiectasis. And it can also lead to left-right asymmetry defects because we have also cilia in the embryonic node. And if these cilia are not functioning properly, then the left-right asymmetry of the body cannot be maintained. And we have like a chance of 50% to have like a situs inversus totalis, or sometimes also to have situs ambiguous. So if these cilia are not functioning properly, this can lead to a disease called primary ciliary dyskinesia, which is a hereditary disorder, usually autosomal recessive, and it's caused by this defective ciliary motility. To diagnose PCD, we just actually need different tools. And the first one, of course, is like to have clinical symptoms, which can show that the patients might have PCD. And we need also other kind of tools, which like the nasal nitric oxide, which is usually low in patients with PCD, the genetics, which will show us if there are mutations like leading to PCD, the high-speed video microscopy to show if the cilia are moving properly, the transmission electron microscopy, which will show us how is the structure of the cilia, if it's like really maintained, the immunofluorescence microscopy, which will show us the distribution of the proteins in the cilia, and at the end, in vitro ciliogenesis to see if we can have like growing cilia in the cell culture. So in order to diagnose PCD according to US guidelines and to European guidelines, we need the clinical symptoms and we need at least 2 other tools that confirm the disease, because each one of them has some kind of limitation. So the clinical symptoms, as I already mentioned, we have respiratory symptoms. We have more than 75% having neonatal respiratory distress, chronic sinusitis, chronic rhinitis, daily persistent wet cough, recurrent lower respiratory infections, bronchiectasis, recurring otitis media with effusion, and sometimes also hearing impairment. We can also have organ laterality defects. 40 to 60% have situs inversus totalis, and about 6% have heterotaxia and have congenital heart defects. And what I mentioned also, we can have like a hint if we have someone with infertility, female or male, or also hydrocephalus. So regarding the genetics diagnosis, so PCD is very heterogeneous. So till now, there is like 39 genes which are associated with severe PCD and 5 genes associated with milder form of PCD. This makes it a bit complicated because we are not looking for a mutation in a single gene, but we already have like more than 44 genes that we have to test to see if there are PCD. We apply in the lab 3 genetic approaches. We make Sanger sequencing, which is the normal targeted just like 1 by 1. We have the gene panel. So we have a panel with all the published genes so that we can check if the patient has a mutation in a known published gene. And if we don't find a mutation, then we proceed for whole exome sequencing and for whole genome sequencing also to like try to find the mutations. Till now, 60 to 70% of the cases are genetically detectable, and the number of genes identified through the years is like different. The peak was in 2013, and now it's like becoming a bit slowly. So for the other PCD diagnostic tools that we need something called nasal brushing. And for this is like quite simple. We need like a falcon with medium, a cytobrush, some microscope slides. The nose is like cleaned really well. The brush is dipped in NaCl, and with like small rotatory movements, we can just like have like some samples that we can spread on slides, put it in cultures, or we put it in glutaraldehyde to make transmission electron microscopy. And this is what we started. We started to have a national screening in Lebanon together with Dr. Khayat. And we had like patients who have some clinical symptoms. They just have like some forms to like fill and like sign. And Dr. Khayat has got like a blood sample from the patients and their siblings and their parents, and also a nasal brushing sample. And they send it to us to Germany to like make the analysis. So we had 3 Lebanese families which have suspected PCD individuals. So as you can see, just for the data protection, I just named them by numbers. So we have the first family, OP3652. You can see that we have like 5 siblings, but there are only 1 female which is affected. And this female is 46 years old. She has chronic sinusitis, chronic rhinitis, chronic wet cough, and bronchiectasis, and she has cytosolitis, so she doesn't have any laterality defects. For the second family, we have 4 siblings. We have 2 females. One is 30 years, one is 33 years old. Let's talk first about the first one. She has chronic sinusitis, rhinitis, chronic wet cough, bronchiectasis, and she suffers additionally from infertility. And she also doesn't have any laterality defects. For the third family, we had one affected male. He's 22 years old. He has also the same respiratory symptoms, but he has situs inversus totalis, which is, like most of the cases, a very good hint that he might suffer from PCD. So to start with this interesting family, the OP3653, so what we did, we just sent it for panel. We checked for mutations in a known genes, and we could see that the affected female, which has infertility, she has a mutation in RSPH9 gene, and this gene is coding for a protein essential for the radial spoke structure in the cilia. And if there are mutations in this gene, then this leads to PCD. And we could find that the parents are both carrying the mutations in heterozygous state, so this is normal, then the female is affected. 2 other siblings, 2-3 and 2-4, were not affected, and they don't even carry the mutation in the heterozygous state. But the second sibling, which was like not referred as affected, when we did the Sanger sequencing, we found that she also carries the mutation in homozygous state. So it could be that her symptoms are not yet like very much pronounced, and they are like a bit overlooked. So so this is why she was not referred as like patient. And when we find a mutation in a gene, we have to, as I said, to use one of the other tools to make sure that this is like surely the causative mutation. So we make immunofluorescence microscopy. And here you have these 2 panels. So the upper panel, you have a control respiratory cilia. In green, you see the acetylated alpha tubulin, which is like a marker of the cilia. In red, you see the RSPH9 protein, which is like localizing to the marker. So it is in the cilia, and you can see in the merged picture that you have this co-localization. When you look at the panel, which is down, the patient carrying the mutation, you can see in the red, where we should see a red signal, there is no red signal. So the protein is not present in the cilia, it's lacking. So we make sure that this mutation is a loss of function mutation leading to no protein. Going for the second family, the OP3652, the female carries a mutation in the RSPH3 gene, which is also coding for a radial spoke protein, which is essential for the transduction signaling in the ciliary axoneme by controlling the dynein arm activity. And we did also, again, to check like by immunofluorescence microscopy, and we could see that the RSPH3 protein is not detectable in the cilia of these patients. Interestingly, all the siblings of like sisters and brothers of this female were all carrying the mutation in a heterozygous state. So it is like very important for them to know this when they want like further to like get married with someone from the family or someone like related, like even also not related, to check if the other couple is like having any problems also in this gene, because then they will have a high probability to get sick children. Going to the third family, this was like a male, as I said, and he carries the mutations in SPAG1, which is a pre-assembly factor needed for the assembly of the motor proteins, this outer dynein arms and inner dynein arms that will make the cilia move. And for this, we check if the DNH5, which is actually a component of the outer dynein arm, is present, and we could see that it's not present in the patient, and the DNLA1, which is component of the inner dynein arms, and we see also that it's not present. Here I come to the conclusion. So based on unpublished data that we collected from an international cohort with about 671 PCD affected individuals, we, from our statistics, mutations in SPAG1, RSPH9, and RSPH3 that we found in the Lebanese population represent only 2.4%, 1.8%, and 0.3% from this international cohort. This means like these genes, because they were like, this is the first PCD screening, it could be that these genes are like more also specific to the Lebanese population and they are more frequently mutated in the Lebanese population. So unlike many other disorders, as I mentioned, PCD is heterogeneous. It requires different diagnostic tools and experience centers, making it sometimes underdiagnosed in countries lacking the infrastructure and expertise. And when we have like a suspected PCD individual, if we perform genetics plus immunofluorescence analysis, this is a powerful combination to diagnose the disease. And actually, just to like last mention, that for centers that will participate in the international PCD registry and they don't have a good access to genetic analysis, we always offer this for free on a research basis. And why is it important to know which gene is mutated in a PCD patient? Because for the ongoing development of a targeted RNA gene therapy, which is now like being developed, it is first very important to know which gene should be targeted, because PCD is not like the other diseases where usually you have only one mutation in one gene, which is leading to the disease. So this like this, I'm done. I like to thank you all. And I would like also to thank my team for providing this like beautiful environment to like perhaps try to help also the Lebanese population. Thank you.
Thank you very much for this lovely presentation, Dr. Hjej. Wonderful work. Congratulations. Now we're going to move on to the last speaker.
Good evening. I want to present Madame Stephanie Mitri, who is currently a second-year fellow in Pulmonary and Critical Care Department of LAU Medical Center. She has completed her internal medicine at LAU Medical Center and received her medical degree from the same university. She wants to speak about a case of Ehlers-Danlos syndrome with obstructive sleep apnea. Dr. Mitri.
Good evening, everybody. I'll be presenting a case report about Ehlers-Danlos syndrome and obstructive sleep apnea. So this is a case of a 50-year-old male who's a non-smoker. He has a BMI that is borderline of 27.2. Initially, he was referred by an ENT specialist because of excessive daytime sleepiness. His Epworth sleepiness score at the time was 17. He suffered from severe snoring that worsened over the last year, associated with dizziness and morning headache. His past medical history is relevant for the diagnosis of Ehlers-Danlos syndrome since childhood. However, we have no details about the classification nor the type. He had recurrent joint dislocations, recurrent injuries with fractures and recurrent surgeries. He has hypotonic bladder necessitating multiple daily catheterizations. He also had hypertension, dyslipidemia, GERD, and chronic musculoskeletal pain. His sleep apnea was clinically suspected by his treating physician at the age of 40, however, was never worked up. At the time, he was given an auto CPAP treatment that was not tolerated, and he was lost for follow-up. He then presented at the age of 50 to an ENT specialist because of worsening of his symptoms. Then he was referred to ARC Sleep Clinic, where he underwent an attended in-lab polysomnography showing a severe obstructive sleep apnea-hypopnea syndrome. His AHI score at the time was 107 with severe oxygen desaturations. His oxygen saturation fell below 90% during at least 16% of his sleep duration, and he suffered from severe sleep fragmentation. Here on this graph, we can see that he had frequent sleep fragmentation. He could not maintain himself in a specific sleep state. He jumped from being in deep sleep state from N3 to N2 to N1, and we can see that he had frequent desaturations associated with his sleep apnea. He had few hypopneas, no RERAs. He had frequent leg movements related to his arousals from sleep. And we noticed that his apnea was not related to a specific position. And you can see when he was awake, you had no apneas. Here as well, we see his frequent apneas followed by his arousals, and we can see as well the desaturations associated with his apnea. So we come to our topic. What is Ehlers-Danlos syndrome? It is a group of connective tissue disorders with heterogeneous, inherited, clinical, and genetic characteristics. It is part of the joint hypermobility syndrome that includes several disorders such as EDS, Ehlers-Danlos, the Marfan syndrome, osteogenesis imperfecta, and other rare syndromes. So as we said, it is clinically heterogeneous. It has been classically divided into 6 types: the classical hypermobile, vascular, kyphoscoliotic, arthrochalasis, and dermatosparaxis, with the underlying collagen abnormality being different for each type. And ever since 2017, we have a new international classification proposing 13 different subtypes transmitted either through autosomal dominant or recessive genes. And we have the 9-point Batten scale that helps to screen suspected cases of hypermobility. So it is a multisystemic, variable clinical manifestations, mainly affecting the skin, the ligaments, the joints, blood levels, blood vessels, and internal organs. It is part of the joint hypermobility syndrome. And here in these 2 pictures, we see that it is very easy for these patients to hyperextend their big toe and hyperextend their fingers. The prevalence of EDS, including all subtypes in the general population, is around 1 for 5,000. And the hypermobility type, which is the most common subtype, has an incidence of 1 in 10,000 and 1 in 15,000. However, prevalence is very difficult to evaluate as it is directly related to the physician awareness and changes in the classifications. We can have mild asymptomatic forms. They are the most common phenotypes, but however, they are underdiagnosed, and they should not be regarded as curiosities, as they may have severe systemic complications, mainly cardiovascular. Symptoms are, however, usually present early in childhood. Clinical manifestations vary from mild asymptomatic skin joint hyperlaxity to severe physical disability and life-threatening complications. So what relates EDS and OSA? What predisposes these patients to have OSA? These patients may have cartilaginous defects, including the nasal cartilages, the maxillary cartilages. They can have craniofacial abnormalities, such as mandibular retrognathia, high arch palate, increased pharyngeal collapsibility, vocal cord abnormalities, scoliosis or kyphosis. And all these above increase the risk for sleep-disordered breathing, particularly obstructive sleep apnea. And now we have robust data showing that OSA has cardiovascular adverse effects, including aortic complications, that are added to the risk of Ehlers-Danlos syndrome's own cardiovascular complications, and that treating OSA may prevent or improve these complications. And EDS patients often have symptoms such as fatigue, daytime sleepiness, joint pain, dizziness, anxiety, phobic disorders, and dysautonomia. But however, these symptoms are also frequent symptoms in patients with sleep-disordered breathing. So it's very important to draw the line where these patients may actually have obstructive sleep apnea or sleep-disordered breathing. In a recent study, Gale et al. In Thorax 2017, it evaluated the prevalence of OSA and the quality of life in a parallel cohort study of 100 EDS patients that are matched to healthy control. And they showed that 23% of these patients suffered from symptomatic obstructive sleep apnea in comparison to 3% of healthy controls, and that the severity of OSA was positively associated with their symptoms of daytime sleepiness and their lower quality of life in the EDS group. Setke, Kale et al. In 2019, systematic review and meta-analysis showing that EDS patients were on average 6 times more likely than the general population to have a diagnosis of OSA. Another interesting study by Guilleminot et al. In 2013 showed that sleep-disordered breathing was not only a frequent referral in a sleep clinic population with EDS, but also EDS suffered from sleep-disordered breathing. They were presenting even for a routine medical care. So these patients had symptoms of fatigue, poor sleep, daytime sleepiness, but they were never referred for evaluation of sleep-disordered breathing. Moreover, CPAP treatment led to improvement of their complaints. So maybe EDS may be a genetic model for OSA because of the craniofacial growth abnormalities. So as a conclusion, the high prevalence of obstructive sleep apnea in patients with Ehlers-Danlos may contribute to their symptoms of fatigue, their daytime sleepiness, their impaired quality of life, as well as worsening their underlying vascular abnormalities. And robust data are now available about the cardiovascular adverse effects of obstructive sleep apnea, and that treating obstructive sleep apnea can actually improve and prevent these adverse effects. So EDSA may provide a genetic model that helps in phenotyping obstructive sleep apnea. Those data and meta-analysis confirmed that there is an obvious lack of awareness about Ehlers-Danlos syndrome and its association with the high prevalence of obstructive sleep apnea. So early diagnosis and treatment are essential to improve symptoms, their quality of life, and prevent adverse effects, mainly cardiovascular. And a high degree of awareness in the medical community is needed because the diagnosis of Ehlers-Danlos syndrome relies mainly on the clinical features. And thank you. This is a picture of Dr. Danlos with his pupils.
Okay, thank you very much for these presentations. I think we're going to open the floor for a few questions on the different presentations. If I may, since I'm here, I'm going to start with one question to Dr. Sher. Dr. Sher, can you comment on how you thought that the sample population was representative of the whole country? Because it's a 600 individuals, right? So what did you use as a tool to make sure that this is a representative sample?
So actually, the sample we chose was representative of the Lebanese population. We chose the percentage of 31% as the last study made in Beirut as people with high risk of developing hypopnea syndrome. And this was calculated on the ESS, that score. Epworth. Okay, so using this, we with the statistical help, we thought we needed 374, I guess. And actually, we chose two villages from each Kaza. And from each village, we chose people randomly. We went to each village and we chose people randomly. And this was like a bit of representation of the whole population. So based on the percentage of the last study made in Beirut.
I see.
Thank you.
Great. I actually have a question for Dr. Hjej. Can I do that, George, or do you have anyone there?
No, please go ahead.
Okay. So Dr. Hjej, you mentioned that the mutations in the three genes, the SPAG1, the RSPH9, and 3, were unique, and they're rare in the general population, but they seem to be, common in the Lebanese people, which, it tells us how unique of a species we are as Lebanese people. But do you know what the prevalence of these mutations are in the general population that doesn't have PCD?
Yeah. So for the so usually when we count mutations as like causing PCD, they are like really, really rare. So less than 1% in it should be less than 1% so that we consider it like really it is like the disease causing one. And in the general population, I mean in the worldwide populations. So this is first. And second, so usually the top 10 genes which are mutated in the worldwide population, like causing PCD, it was like really surprised when I saw that the first 3 genes I found in the Lebanese population are from the one which was like really the low common one. So one for the, I mean, in a cohort where we have like 3,000, 4,000 patients that we did not analyze fully, but still in this cohort, I have barely few patients from worldwide that have these mutations. So I was expecting that I will find mutations in the really prevalent ones, because we have also samples from Egypt. We have also samples from Jordany, and it was like really totally different, also from Cyprus. So I think this is, yeah, I mean.
So do you have samples from the Lebanese population that don't have PCD, or you only have the PCD patients?
No, I have only the PCD patients.
I see. Okay. Okay. That's great. Thank you. George, do we have anything else? I have one more question for Dr. Mitri, but I'm happy to wait for the floor.
Yeah, well, maybe I can meet you to it and ask Dr. Mitri one question. Dr. Mitri, the case report you presented, do you think that the fact that the patient has Ehlers-Danlos is what matters, or were the same? In other words, was the severity of the sleep apnea worse because the patient had Ehlers-Danlos, or is there a different phenotype we should be looking for?
The fact that he has Ehlers-Danlos syndrome first predisposes him to have obstructive sleep apnea. Now, often Ehlers-Danlos patients with obstructive sleep apnea have severe obstructive sleep apnea, and it is often debilitating in their lives and affects their quality of life. And as I've mentioned, there is a genetic model. So the different mutations in the 13 subtypes, it defines your phenotype, and it phenotypes your obstructive sleep apnea. So whenever you have a patient who has a family history of Ehlers-Danlos and is presenting with hyperextensibility of their skin, they have joint dislocations, a screen for hypermobility to start with, and then maybe if you have the whole picture together, you can do the genetic phenotyping, the genotyping basically, and based on that, you follow them up according to their symptoms, and then based on their genetic predisposition, because we have different types, and especially there's the type 4, that is the vascular one. These patients are predisposed to have vascular anomalies. They often present with rupture of a large vessel, such as the aorta. They have uterine ruptures, and often this is life-threatening. So if you can genotype them, first of all, you can almost predict what complications they can have, and as well predict the severity of obstructive sleep apnea. But of course, an in-lab polysomnography is often essential at first to determine their apnea-hypopnea syndrome, apnea-hypopnea index, and determine where they are at the spectrum of the obstructive sleep apnea.
Thank you. Dr. Bourjaidi, you wanted to ask a question.
Yes, so we heard earlier about sleep apnea and heart failure. Do you know what your patient's cardiac function was, and could that have contributed to the severity of his sleep apnea?
Yes, his cardiac function was relatively normal. He had a normal ejection fraction. Because of his age, he had no diastolic dysfunction. However, these patients, the Ehlers-Danlos and the obstructive sleep apnea, as we know, both have predispositions that are mainly cardiac and vascular. So we have to consider that these patients are at utmost risk regardless of their cardiac function, because we well know that we cannot determine the effect at the micro level of these diseases, because Ehlers-Danlos affects your collagen, which is basically the extracellular matrix of basically all your body, your internal organs, your skin, your ligaments, everything. So you're adding on the obstructive sleep apnea's own cardiovascular problem, and you're adding on the EDS complications that are mainly one of many cardiac. So you have to consider that these patients are at risk, regardless.
I guess that should take care of things. We have one question that Dr. Sarofim asked, but I don't think it's pertinent to the presentations. He was asking about the use of CPAP in COVID-19 infected patients that have sleep apnea. You ladies want to take a trial at the answer? No? Stick to your abstracts.
I think they should.
Are we talking about a patient who's hospitalized?
Use it alone in your own room, Evelyn. Don't use it elsewhere. That's what I would say.
I believe if they need their CPAP, let them take their CPAP.
Yeah, exactly. Okay, thank you. Thank you very much, ladies. If you could maybe step aside for a few minutes so we can deliberate, and then we'll invite you back in. Thank you so much.
Good luck, everyone.
avec nous jusqu'à cette heure-ci. Je remercie les trois présentateurs de posters et j'encourage d'autres résidents et étudiants de présenter pour les congrès qui vont suivre. Je vais laisser la parole à Dr André pour qu'il présente lui-même les prix de ce soir. Les prix, je rappelle, sont présentés par l'Association franco-libanaise de pneumologie pour la deuxième année. Dr André Bergulas.
Et donc, oui, l'association franco-libanaise de pneumologie que je représente donc invite les deux concurrents que je vais nommer à la prochaine réunion de la CPLF. Alors, nous avons choisi Madame Aurélie Chouker et Madame Stéphanie Mitri pour être les lauréats de ce prix. Donc, qui si ça ne se passe pas en présentiel cette année à cause de la pandémie, certainement sera remis à l'année prochaine en présentiel.
C'est le voyage pour assister au congrès de la SPLF. Ce n'est pas que, Dr Hajej, votre présentation est très supérieure et overqualified. Les prix sont pour les trainees, donc c'est pour les étudiants et les résidents. Définitivement, vous avez fait une très belle et brillante présentation, mais comme on vient de le dire, vous êtes overqualified pour le prix. Merci beaucoup et à demain. Restez avec nous.
Merci.
Merci.
Au revoir.
Thank you.